Good evening, ladies and gentlemen. I'm Jatinder Bali, and it gives me great pleasure to welcome all of you to this second edition of the National Skill Transfer Initiative. The topic that we're going to discuss today is post-refractive surgery cataract extraction. It's a high volume topic. People have a lot of queries in their minds, and it is not really very well covered in the books. So what we've done today is we've picked up some of the best speakers in the country. We've picked up high volume surgeons. We've picked up Dr. Nichlani, Dr. Rajendra Prasad, Dr. Gaurav Luthra, and we are going to pose a lot of questions to them. I welcome our chief guest for the evening, Dr. Mohan Rajan, a titan in his own right, and our national coordinator, Dr. O.P. Anand. Our moderators for the evening are, can we have the screen share, please? Our first moderator for the evening is Dr. Anu June. She is an assistant professor at the Guru Nanak Eye Center, which is attached to the Maulana Azad Medical College. She is the associate editor of the Delhi Journal of Ophthalmology. She has been very actively involved in all our programs, and she is one of the moving forces behind our gonioscopy and perimetry hands-on.
Dr. Bali, sir, you got muted.
Yeah. The glaucoma and perimetry hands-on skill initiative, which has gone into the second year today. The second moderator for the evening is our Prasanna Venkatesh Ramesh. He is the research director and the head of glaucoma at Mahatma Institute at Trichy. He is the associate editor at the Tamil Nadu Journal, and he is also the assistant editor of the glaucoma section of the Indian Journal of Ophthalmology. He is a very famous innovator and an upcoming bright star. This particular skill transfer initiative starts off with webinars, goes on to physicals, and then to hands-on skill transfer. We've started onboarding for certain programs, and without further ado, I'm going to hand you over to our moderators. Over to you, Dr. June and Dr. Prasanna.
Thank you, sir.
Thank you, sir, for having us moderate this wonderful session with all the stalwarts in this elite evening. Dr. Jatinder Bali, sir, needs no introduction, but we'll introduce you in a very short and succinct way, sir. He's a chairman, International Research Committee, International Society of Manual Small Incision Cataract Surgeons. Sir is also the chairman of National Skills Transfer Initiative, and we are in the second capsule today. He's a chairman DOS subcommittee for IT, practice automation, and he's also the library officer of DOS. He's also the associate editor of Global Journal of Cataract Surgery and Research, and he's also the chief editor of 1 Minute Ophthalmology. He has also authored many textbooks, one being the basics of biostatistics, a manual for medical practitioners, and he's also formerly assistant DNB coordinator and a nodal officer. So we welcome you and thank you for having organized and planned this wonderful inception of National Skills Transfer Initiative. Next, I take the liberty to welcome the very prolific and dynamic chief guest of today, Dr. Mohan Rajan sir, Professor Dr. Mohan Rajan sir, who is the head of the Super Speciality and Postgraduate Institute in Tamil Nadu, the Rajan Eye Care Hospital. Sir is the medical director and the chairman there, which is affiliated to the National Board of Examinations. Is also the adjunctive procedure of ophthalmology, Tamil Nadu MGR University. Sir has also been the past president of our state Tamil Nadu Ophthalmic Association and the visiting professor of many institutes, namely the Savita Medical College. Sir is also the past president of IRSI, secretary of Shankara Nitra Alumni, and he's also the AAO's member scientific committee for the year 2017 to 2020, and he's very active in the Rotary District 32/32, the 3232 district. Sir is an anti-segment and a posterior segment surgeon, more than 2000 papers, 140 live surgeries, several innovations like the quick chop and the Mohan Rajan chopper, etc., with more than 70 awards and the best doctor award twice from the government of India. He has several national and international awards. To name a few is ASCRS and ESCRS. He has also had the record number of OPL victories, 65 till date, which is a world record. So we welcome you, sir, for this wonderful evening. And we also welcome our national convener, Dr. OPRN, sir, who's also the professor of ophthalmology, who's an ex-HOD ophthalmology, Northern Railway Central Hospital, and the Ministry of Railway, the New Delhi. I would like to call upon Dr. Anuj June, my co-moderator, to invite the first speaker. Over to you, Dr. Anuj June.
So without much further ado, let's welcome our first speaker for the evening. We welcome Dr. V.K. Nishlani, who is the director of SV Eye Care in Bhopal. He held the posts in Madhya Pradesh State Ophthalmic Society. He was the chairman of scientific committee of MPSOS previously, and also the honorary secretary and editor proceedings. There was also the honorary secretary of the Bhopal Divisional Ophthalmic Society. Again, he's an anterior and a posterior segment surgeon with a special interest in phaco and refractive surgeries, with multiple scientific talks and presentations in international, national, and state conferences, with live surgical demonstrations in various society organizations. He is an evaluator of papers in multiple proceedings like AIOS and MPSOS, and also a gold medal awardee by IRSI. So we welcome you, and we can't wait to hear a few words from you on this very important topic, that is biometric considerations in post-refractive cataract surgery. Over to you, sir.
Thank you, Dr. June, for the kind words. And first of all, I would like to thank Dr. Jatinder Bali. He has started a wonderful program of national skill transfer and carrying out this wonderful series of these events. Simultaneously, I would like to thank the team members of his team and other faculty members, like Dr. Mohan Rajan, Dr. Anand, Dr. Prasanna, Dr. Gaurav, and other members as well. So let us start with the first talk, which I am going to present on now this is the first slide. So the biometric consideration in a post-refractive cataract surgery, this is one of the important things which we always consider before doing any of the cataract surgery. In the cases which have already undergone the refractive surgery, whether it is a laser vision correction surgery or the radial keratotomy, because nowadays we are getting these variety of cases very regularly. There's no financial interest. Coming to a few of the basic things, nowadays the cataract surgery is has become a refractive kind of surgery. Patient always wants to have a normal 6/6 vision, and simultaneously, whenever we are planning to have any kind of premium IOL to give our best results, we must be very accurate in doing the IOL power calculation, that too particularly in these cases, the post-refractive cases. Here I would like to stress one of the important things, the measurement tools. The measurement tool is the optical biometry, has to have with us, but if it is not there, there are other means, and how do we come to across and calculate the exact IOL power calculation of such patients, that we'll discuss upon. But there are few advantages of optical biometry, because it goes from the visual axis, as there's a point source of a light or in an optical biometer where the fovea fixes, and it takes away the errors of geometric axis, which is being measured by normal ultrasound. So there's an error of 200 micron. It uses a shorter wavelength, so the penetration is good and you get a proper axial length calculation. Any of the patients who have been already implanted with a pseudophakic or phakic IL, or if they are aphakic, the measurement is better with the optical biometer. And in a patients who have got staphyloma or silicon filled eyes, where you definitely does not require any kind of correction as far as the silicon filled eye is concerned, you definitely get a good or exact axial length calculation. Yes, coming to the slide was not moving, unfortunately. We have been using, I would say, second and third generation. Nowadays, the fourth generation family have come, where the Barrett's practically has already changed the scenario and has given us the better way of understanding and calculating the IL power calculation. Simultaneously, Hill RBF family is again one of the good tool. Initially, we have been using Holiday 2, Hoffer's Q, SRKT, and in a different eyes or the predisposition of the eyes, like less than 20 millimeter, between 22 to 24, and more than 24 and 26. So these were the usual family which we were taking out. But with the advent of this fourth generation family, we have been able to give the better way of IL power calculation. So what these formulae use the corneal power to do? Corneal power is directly used in a Vergen's calculation to predict the post-operative refraction. One point is this. Second, there is a ratio between anterior and the posterior surface, which extrapolates and calculates the predictive effective lens of a position. So effective lens position and the corneal curvature. These are the two important things basically we need to see or need to recalculate in these eyes which already and have undergone the refractive surgery. So the problem with these eyes is this, that refractive surgery alters the corneal curvature and introduce the error in both the measurements of corneal power and prediction of the ELP. There is an underestimation of required IOL power in a myopic refractive surgeries, and simultaneously the overestimation IOL power in a hyperopic refractive surgery. Additionally, the RK surgery gives irregular astigmatism. So looking to the keratometric alteration, what happens? The radial keratotomy flattens both the anterior and the posterior corneal surfaces. It is only the small central area which is virgin, which is not being affected in the radial keratotomy patients. The effective optical zone diameter can significantly smaller than the measurement zone of a standard keratometry. So somehow we need to find out that virgin area, because the tools are going to measure a bigger area. These cornea often have an irregular astigmatism. That is again an additional thing because of the incision. Furthermore, there can be a central flattening after the cataract surgery due to corneal edema. This we usually see on next post-operative day or the few of the days after the surgery, that every time patient comes and he has got the fluctuating vision. So these things are to be kept in mind. Therefore, in a post-RK surgery, the true corneal power can only be estimated taking into account a very small effective optical zone, that is 3 millimeter. If I say, if we take 2.2 millimeter, the central zone would definitely be a better idea. So here is a radial keratotomy which flattens both the anterior and the posterior, but in a laser vision correction, it is only the anterior surface which is being changed. So there's a correlation between the anterior and the posterior corneal surface, which again, there's a fixed ratio which keeps on changing with these refractive surgeries. So error in an effective lens position, coming to the second point, what keratometric readings we definitely need to see. Coming to the effective lens position, the virgin eye has got a relation between the anterior and posterior corneal curvature that extrapolates, or the net corneal power gives us the idea that what would be the effective lens position. This is all regression formulae. They've got a fixed pattern that what if patient has got this K reading, the effective lens position would be such. After radial keratotomy or any LASIK vision correction, the corneal power is decreased and the effective lens position estimates become too low because it measures that with a flatter cornea, it has got a small anterior chamber depth. And this is how the estimation of IOL power changes and the vice versa happens in a hyperopic situation. So what we need to have some special methods to reduce this error and to recalculate all these things. So what to do? We need to obtain a true corneal power and obtain an effective lens position so that we come to a proper or a true IOL power calculation, which is being modified with these two errors in a refractive surgery. What is the method to do it? There's a clinical history method, the contact lens overcorrection, topographic based LASIK adjustments, central ring topography, and net corneal measurements. Clinical history, if I say that radial keratotomy, of course, is started long back, so we may not get a proper history of all the records what patient had been given at the time of radial keratotomy surgery. We have been keeping records of LASIK vision correction and giving it to the patient so that in the future, if they undergo cataract surgery, they can have these measurements available at the time of cataract surgery. But sometimes, or many of the times, if I say, these data are not available with the patients. And simultaneously, whenever there is a cataract, you definitely can't rely much on the clinical history method. Other part is the contact lens overcorrection. This is definitely a better method, but once the patient has developed a sufficient amount of a cataract, you really does not go any or can't do any kind of refraction. That time you definitely need to have another tool to measure a true corneal power. So these are the some topographic based post-LASIK adjustment keratometry, where this two formulae, the Koch and Wong formula and Sharma's formula, they have got some correction factor. If you add on this correction factor on the topographic value which is available with you, that practically gives you a corrected corneal power which can be put into the formulae and you can get a near to normal or the emmetropic kind of correction of IOL power calculation. So I basically depend on these two formulae, though there are some other methods which we have been discussing later on. Now you need to measure the net corneal power measurement with the topographic method. And here we have the tools which are available, the slit scanning tomography, Schlimpfung, and optical coherence tomography. These tools, they measure the anterior and the posterior K readings, corneal power, but you need to find out the exact 3 millimeter zone to find out or to calculate the net corneal power. So these are some additional methods, OpScan, Pentacam, and OCT, optical coherence tomography. Apart from it, we can have a correction of cornea with a double K family. Of course, here we more depend on holidays too, where it has got incorporated slots or the spaces where you can feed on the refractive error, the the value and the power for which it was corrected, then definitely you can have a true K value. But many more times, this holiday 2 formula, which is not available with us as a software or in a machine, then definitely the SRKT formula, holiday 1 formula, and Haggis with a little bit correction of Amberberry charts which are given, you can have those corrections added on what you calculate, and definitely you come up with that true IL power calculation which is required for implantation of these post-refractive cases. Musket formula, yes, this is again one of the formula which is more reliable, and gradually it is being calculated for post-myop and post-hypermetropic correction. So these are the some charts which are available for the myopic, hyperopic, where you can have the axial length and the dioptric correction, and simultaneously you can keep on adding the power in the calculation which you get from the IL power calculation, and then you come to have a IL which is a corrected IL power calculated value. There are some recommendation in the post-RK patients. Averaging the topography corneal power of a central 3 millimeter area. Once again, I insist if you can have 2.2 millimeter area, which is practically virgin. So you need to find out from your topography machine if it gives you that area of central power of that zone, that definitely gives you the true corneal power. Second is the double K formula, and with the correction of the chart, Haggis L particularly, it calculates anterior chamber depth independently in spite of all those refractive corrections. And once we get anterior chamber depth independently corrected or calculated by this formula, and if we are able to calculate the true or the net corneal power, then this formula definitely is going to give you near to the ematopic correction. Now, recommendation in laser vision correction, this Koch and Wong, Shamas practically is all available in optical biometer to give you the true K. Haggis, of course, we have discussed a little bit of it. Now, these are the different formulae which can correct IL power calculation in post-radial keratomy and the post-laser. So double K formula corrects in both, Hoffer's Q in both, Haggis formula in a laser, Muscati and Koch and Wong for laser correction vision. Nowadays, we are very fortunate enough that Barrett's is all open to the website where you can calculate the true K power. You definitely need to put the readings which you have. Here it is a myopic LASIK, you can have hyperopic LASIK, you can have radial keratomy, need to feed out everything, and whatever the vision correction has been done, that gives you the true K value. And once that true K value is available, you can definitely go ahead with the proper IL power calculations. This was the older one that we have been using from ACRS. There, of course, you need to have a pre-LASIK data and the post-LASIK data available with you. This helps you in many more times that these zones of 1, 2, and 3 millimeter topographic value is available, and can give you a power arriving near to the emetropia. I would like to stress to discuss this slide. Here, whatever pre-LASIK data are available, patient do remember that what was the correction which was available. and the post-classic data which is available and calculating out the corneal power from 1 millimeter to 3 millimeter zone. If we have got that kind of topographic machine is available, putting out the ultrasound or the optical biometer, anterior chamber depth, axial length, lens thickness, white to white, and then you can have these formulae to calculate the IOL power which is to be required for implantation. So in conclusion, I would just like to emphasize on two or three things more. Even if we are calculating out with an ultrasound kind of method, try to use that ultrasound probe which has got a infrared light, the red light which we see practically in all of the ultrasound, rather than measuring the geometric axis, put the light in a way so that in an apex of the cornea and ask a patient to look into the light. So that really measures the optical axis or the visual axis of a patient. So we are avoiding the geometric axis with a normal ultrasound kind of thing. Try to see the tear meniscus has to be minimum, and simultaneously you are not going to give any pressure over the apex of the cornea. So there shouldn't be any indentation and there shouldn't be much of the tear meniscus. So the error of low calculation and the higher calculation is avoided. If it is being used with the immersion kind of thing, definitely that would be a better idea. But just to give you an idea that we can do that way. Now, if we are able to find out the true K value, what we have discussed, then anterior chamber depth and the thickness of the lens and the axial length, if those things are independently being measured by you, then those things can be put into a Barrett's formula, and definitely you are through going to have near to the normal IOL power calculation. So whatever is available with you, but nowadays everybody relies on Barrett's because it has got a more data and it gives a more predictable results. So better it would be try to have IOL power calculation from 2 to 3 tools or 2 to 3 methods, and try to see which one is going to give you a higher power of IOL in a myopic and a low in a hyperopic that suits you to bring you to the exact IOL power calculation. I think this is being discussed from other speakers. So this is what I had to say. Thank you. Thank you, everyone.
Thank you so much, sir, for such an extensive talk and covering the IOL formulas so widely and extensively, taking us through all the theoretical as well as the practical and the regression formulas. Sir, in your personal use, which formulas do you prefer? Is it just the Barrett, or do you take a mixture of all these? Like you were saying, we take multiple formulas and readings and take the higher or the lower power in myope versus a hypermetrope.
See, I have got access to optical biometer. So optical biometer has got Shama's formula. So that is the one point which I always put into in my consideration. But apart from it, I always try to do a topography of such patients, try to minimize it to 3 millimeter zone of topography, then try to see what is the axial length is being coming up with my immersion and the optical biometer, anterior chamber depth, and then putting it into the Barrett's formula. So I have, I mean, done calculation with these 2, 3 tools that practically gives near to the same value with a difference of 0.5 to 0.75. And I never forget to see the charts, which is for the correction given to the different axial length, and if patient remembers that what exact number of or the power which was corrected as a refractive error. And I always take the highest IOL power or just add on 0.5 as my additional the experience which I usually get from my surgical past experience from operating such patients, that I usually add 0.5 diopter on top of whatever comes as a maximum of myopic patient. So practically I land up with near to normal emmetropia.
So what about total cataracts and dense posterior subcapsulars where optical biometry might not give a good reading?
There, you need to rely on more on immersion kind of thing.
And so what
Dr. Rajan, what is your preferred approach, sir?
First of all, let me
you do
compliment.
iridometry by multiple?
Yes.
No problem. Let me compliment Dr. Nishlani for the wonderful talk. I think he has covered everything. The
Yeah.
most important thing is, please understand one important thing which you are facing now today. It's a very practical problem. Okay. The practical problem is that please go into the history of the patients, okay, before you do the surgery, because I have burnt my fingers a couple of times. The reason is that they've had some PRK or LASIK 20 or 25 years back, and they would have forgotten about it completely. So, and this I learned, and after some time, because the patient don't even remember 20, 25 years, 96, 97. And at the time, I think Dr. Babu Rajan was first to start the PRK in the entire country in Chennai. And he used to do a lot of PRKs. And we get a lot of patients from that time also now. So patients who have had history of laser, many people don't forget that they have had a LASIK laser. Many people, and of course, pre-operative data is very difficult to get because many of them don't even remember the power. So I think that pre-operative data and all those formulas is gone now. I rely on you, Master 700. I'm giving you very practical points. Okay, this IOL Master 700 is a fantastic, it's got a swipsosity, and it takes in a lot of what you call features in that. And if you have access to if you have money, put the money in IOL Master 700. That's one of the best tools, and it's got all the formulas incorporated into that. So automatically you put the post-LASIK formula because it is taken into so many variables. One of the main features in refractive cataract surgery, in the refractive, post-refractive surgery cataract, is that very difficult to identify the corneal power. Okay, and because it's very difficult to identify the corneal power, and also difficult to know exactly where the lens will sit. That is called the effective lens position, ELP. The ELP we can find out in a normal emmetropic eye, but in a post-refractive surgery, the entire ball game changes. The distance between the anterior and the posterior corneal curvature and the posterior corneal curvature to the surface of the lens. So everything, the distance changes. There are too many variables coming into account. So now, instead of getting confused, many people get confused which formula to use for what. There is only one universal. That is why it's called universal Barrett universal formula. This universal formula, you can use it across all the spectrum, entire spectrum, short eyes, long eyes, post-refractive surgery, and post-vitrectomy, oil, everything you can use that. And you can, I'll because my experience is so good, I'm sure everybody will also agree with me that the results are really fantastic with Barrett formula. Now, you want to go one step above Barrett formula. There are formulas which I'm using some cases. For example, the hyperopic, I'm using offer Q because hyperopia is the problem. When you have very huge hyperopia beyond when the axial length is less than 18, 17, or you have an non-ophthalmos patient. So all these patients is very difficult because there are no proper formulas for that. So I go for offer Q. I sometimes use the Kane formula also nowadays, which works on artificial intelligence. LRBF we can use, but Kane formula is also very, very promising as well. So I think, Nishlani, you have covered everything. Fantastic talk. But it's always the thing, go into the history. The history is very important. So find out what exactly procedure they have done, whether they were using any glasses. Because these are all patients, they come at 55, 60 years, you think it's a senile cataract. But it would have been a post-refractive surgery and they would have missed it completely. And I have burned my fingers. I had a patient about 1 year back, he didn't even tell the history. Nobody, my assistant saw the patient, and very regular formula we put, and we post-operatively the patient had +7. So that is the problem. So I think we should know the history is very important for us to understand this, because more and more patients are going to come in this category in the future.
The Hoffer Q is actually very forgiving in terms of the ELP. So,
Dr. Bali,
can we have Dr. Anand's this thing? So, what is your preferred approach, sir?
I just what discussion is made by Dr. Rajan and the presentation is very excellent. In fact, what I say that maximum people who are practicing in our country are not having optical biometry. So we should not forget the situation of the people who are not having the biometer in their hand, in their clinic.
Valid point, sir. Valid point.
So we have to give some tips for those people who are working without it, and they have to operate. They cannot refer all patients to the higher centers, in fact, right? They have to run their bread and butter. What
So
I have
everybody,
seen,
Dr. Rajan, everybody cannot calculate a total keratometry.
Absolutely. No, what I'm trying to
I mean, it's a fact. It's a fact.
No, Anand, I fully agree with you. OP sir, see, the problem is, if you want to do premium lenses for post-refractive surgery patients, for example, if you want to put a Synergy or a VVT lens, you need to hit the bullseye. For that, you need an optical biometer. But if you want to put a unifocal lens, you can go this way, that way. Okay?
Agree.
For that, what you require is very important to find out what is called the true net K. True net K. The true net K can be seen by a beautiful topography, or even a pentacam can find out the true net of the keratometry. And then on the basis of that, you can do an immersion and find out the axial length, and you can go for a what you call a unifocal thing. But the problem is unifocal, you can go this way, that way. That's not a problem at all. But in multifocal lenses or premium lenses, you have to be on the bullseye. Consistently, you have to hit the bullseye. So for that, you need a optical biometry. That's why I tell.
So let me summarize it. What you are saying basically is a pentacam, the equivalent K, and the holiday report. In case it is not, like in case IOL master is not available, we go in with the pentacam. That again is
so basically, Dr. Bali, I want to say one thing. We can conclude that the one category who is bearing a optical biometer of good quality, like the i700 is definitely advanced machine. But I think we have to give a word of wisdom for those people who don't have it, that they should do their own assessment of post-operative patients. Like recently, I operated a patient of Kuwait, She was having a post-op of RK. I take a lot of precaution to operate. Dr. Prasad will cover this topic, that how to operate these cases who have a deep RK cuts over the cornea. And finally, the outcome of your biometry, what you have calculated, what you have come out with that.
So what about contact lens over refraction? Like how good or bad is that as a method?
It's definitely a helpful tool for you, and definitely you can not land up with the big refractive surprises if you are using all these techniques. What has been discussed in very detail, I think if the people take the note of it, I think they will not enter with the big surprise. Like one of the case, I landed with the surprise of almost +3 diopter. So that was not a very acceptable situation for the patient, because the post-RK patient we always take as a premium cases. So definitely we have to cover.
Dr. Prasad, what is your preferred approach, sir?
Dr. OP has very validly raised this point of those who are not having the IOL master. Because a few years back, I didn't have the IOL master. Then I was depending on the immersion biometry only. And what I have seen is, like, even the immersion biometry gives you equally good result. There is no problem. If you compare the axial length with the immersion biometer and the IOL master, it's 99.5%, it's equal. I don't see any difference. The point which Dr. Mohan Rajan has raised is the very, very important point is measuring the K, the true K.
Yeah.
That is the most important. See, whether you use for axial length, whether you use for the biometer or you use IOL master, it doesn't make much difference. But how to take the K reading? So you have many, Dr. Nishlani has very nicely described all the way how to measure the K value of the cornea, those who have undergone the refractive surgery. So we have pentacam, we have with topography, and all these methods can be used, and then see like which machine is giving the more accurate and more similar kind of results. So as he said, you have to do it in a multiple, and even this simple keratometry machine, simple one, which we have been using till now, that also gives very accurate results, and especially in RK surgery, where you have a very small optical zone in the center, because the actual keratometer would measure the smaller area of the cornea than the biometer and the IOL master and the pentacam. So it gives more near accurate result with the keratometer. So
I would just like to submit the two comments, very nicely covered by Dr. Prasad and Dr. Mohan Rajan. The true corneal power measurement is very important. So whenever I will say, we keep seeing these kinds of patients, irrespective whether you do surgery or not doing surgery, even your operated patients, what K readings keeps on changing. You keep on measuring with the topographer which is available with you, and there are some autorefractometer which measures 2.2 millimeter zone of the K reading. So that again many more times is sufficient. What practice I do, I keep measuring these patients central zone. One is this, and I, depending upon my past experience of titrating these 10 or 15 patients, nowadays I can say that whatever the calculations I do with the 2-3 the tools, we nearly come to land up with the emmetropic power, and now I have started long back with premium IOL surgeries with these patients as well. So your past experience with the different post-refractive surgeries is very important, that what you have been using. If you don't have access to optical biometer and those higher tools available.
Yeah, I think, sir, it's a very interesting thing that, you just take the immersion biometry, this thing, and you have the cock and wang to help you out there. The catch actually is basically, the ELP is dependent on the anterior surface, the pre-operative K, and the divergence is dependent on our post-operative K. So probably, some sort of a double K kind of a thing. Like, is it because, but then, any kind of a nomogram would tend to bring it back into a normalization mode. And ever since we've had, these Kane and Carmona coming in, I think that would automatically get built into the databases. But I don't know, because, right now, Kane is available, Carmona is going to be available it has been available to select people. So Dr. Rajan, sir, what would be, the take-home message, those with premium equipment available and those who do not have access to it?
No, I think the message is very loud and clear. Everybody has talked about it. If you don't have access to optical biometry, if you have access to optical biometry, no problem at all. You can use any formula and get into. The problem is not the axial length nowadays. The problem is the K. Please understand. The problem is the K for all patients, even for the regular patients. The K is the biggest problem. Okay? And measuring the proper K, if you have a good optical biometer, for example, the IOL Master 700, that's what is called a telecentric keratometry. So you are able to get the number of points and able to get it. So if you're able to get the true net K with your topographer or even manual keratometry, only problem is the manual keratometry measures the 3 millimeter zone. The true net is you need to go on the pentacam and click the center and find out the true net K. And that's what we used to do before the optical biometry used to come. If you have access,
yeah, but the pentacam takes up, I think, 4.5 millimeters, no, sir? The central 4.5.
The true net, you need to go and click the center with an arrow, then you will get the true net.
Yeah,
okay, the true net, the K. So that K you take and then measure the axial length. Axial length is not a problem. You can do it as RP was telling, axial length with your immersion or your optical biometry lens star or whatever it is, it's going to be more or less the same. So it is a keratometry, and because of the keratometry, the ELP, everything changes. That is where I think gives you the refractive surprise in post-refractive surgery. That is, I think, that is where we have to concentrate. If you are able to get the true net, and by your own experience, as Nithrani was telling me, your own experience, you know exactly what is your true net and how where you stand by doing a lot of patients, and then you can probably arrive at the thing. Only thing is, when you have an optical biometry, you can be 100% sure to be bang on the target, even if you're using a multifocal or a premium lens.
Right.
When you're using a immersion biometry and the true net, you may be off by about 5-10%.
True.
And the 5-10%, no, you cannot, in a premium practice, if you have the 5-10%, you cannot afford to lose these patients. So those patients will be, that is a thing which I'm a little concerned about. That's all.
I think that
Fantastic
was
presentation,
wonderful.
Dr. Nichlani, sir.
Yeah, that was a wonderful discussion too. Quite a lot of practical aspects, especially from people who've been doing these premium IOLs and not so premium IOLs and refractive surgeries. And I'm sure all of us can take a lot of pearls from this. I now request Dr. Prasanna to introduce our next speaker.
Thank you, Dr. Anu. And thank you to all the stalwarts for such a wonderful discussion and even enlightening us on how to go about things, the points on the telecentric keratometry or how to arrive at the true K. I think these are all the take-home messages of the wonderful session. So over to the next speaker, Dr. Rajendra Prasad, sir. Sir is currently the president of Delhi Ophthalmic Society, and he's a director senior consultant in RP Eye Institute Research and Training Center, New Delhi. Sir has been in active continuous research and innovations for the past 35 years with publications of original work in national and international journals. Some of his innovations speaks volumes, such as the terminal chop technique, sewing needle microcapsulotomy, the terminator, the wedge tool, the hydrodissect for PPC, and for which the National Innovator Award for 2018 by the National Constitution IMA was given to Sir. Sir has many national and international publications with 10 in number and 3 chapters, and he has won the best video in all the national and international conferences, AACRS, IRSI, AOS, ROSCON, and AACRS once again, to name a few. He's also the recipient of the Gold Medal Award in IRSA 2017, and he has numerous orations and paper presentations, many instructional courses, to name a few, on refractive surgery. Over to you, sir, to enlighten us on the next topic of today's wonderful evening.
Thank you very much, Dr. Prasanna, for the nice words, and good evening, everyone. Thank you, Dr. Jitendra Bali, for giving me this opportunity to be here with all of you in this beautiful evening and this very important course what you have started. And good evening to all the panelists and the moderators, so those who are here, and those who have already joined us, and all the guests, those who have joined the webinar. So today's topic, which I'm talking about, is it's the post-RK cataract surgery. Dr. Nichlani has covered most of the part of the topic. So I will actually not go into the details of the IL power calculation, but there are certain preoperative and intraoperative consideration when you are talking about the post-RK cataract surgery, because post-RK cataract surgery, performing cataract surgery in a patient with previously underwent RK, they present a numerous number of challenges for the cataract surgeon. And it actually requires extensive planning to achieve the refractive target. So this is what we have been discussing till now with Dr. Mohan Rajan and Dr. Nichlani. In addition, preventing intraoperative and post-operative complications is very critical in maintaining the corneal integrity, which is very important in post-RK surgery, and optimizing the refractive outcome. IOL power predictions are affected by refractive changes, which is induced by both cataract progression and the corneal surface irregularities. Intraoperatively, it is of paramount importance to decrease the possibility of RK-wound dehiscence, which is very, very important, by avoiding the intersections of the main entry incision with the prior RK incisions and by preventing the high IOP. Oil power calculation has already been discussed in detail, but these are some of the formulas. These are some of the formulas like Barrett-True K with history and the partial history. So these are the preferred oil power calculation formulas for me, especially in post-RK cases. And if you have a refractive data before and after RK, which is not available, then you can use the Barrett-True K, no history, and standard Haigis formula also. But out of them, what I find the best for the post-RK cases is the ASCRS IOL calculated formula for prior RK surgery. So with this, I'll go on to a case scenario. I'll just take up a case and then we can have the discussion on this particular case. And this is a 56 years old female who undergone right eye 8 cuts and the left eye 16 cuts RK surgery in 1994. And this patient later on had a progressive hyperopic shift of plus 3.5 diopter in the right eye and 2.75 diopter in the left eye. Then she underwent right eye cataract surgery with IL implantation of 25.5 diopter spare. And after the cataract surgery, she had a refractive surprise of plus 3 diopter with the implantation of the 25 diopter spare of the IL. The central corneal power was taken up with the IL master in the beginning and the axial length also. And the formula which was used for this particular patient was ASCRS IOL power calculation formula. And this patient, as you have seen, there was a refractive surprise of plus 3 diopter sphere, and the IL was actually implanted 25.5 diopter. So ideally, this power should have been 25.5 plus 3 and half of the plus 3, that is 1.5. So it should have been 30 diopter sphere should have been implanted, but the IL implanted was 25.5 diopter, which was given by the ASCRS or IL calculation formula. So this patient was taken for the IL exchange, and the determination of the IL power and the surgical issues were the important point in this particular patient. We took up the K reading from the pentacam, and this was the K reading which was given by the pentacam. This is the EKR value of 32.2 diopter. IL master actually gave the K value of 34.2 and 34.88 diopter. The axial length was 25.11 and AC depth was 2.8 in this when we took up this patient for the IL exchange. And we use ASCRS IL power calculation formula for this particular patient. Oh my God, sorry. Some problem. So the IL power which was detected with the ASCRS calculation formula was 28 diopter sphere, and went ahead with this IL power calculation. Roughly got the result, and the main incision, as you can see, the important point is we have to give the incision between the intersection and do not include in the incision, the RK incision should not come into that. So we have to be very careful, and this was hook and flip technique. We just took out the IL from the capsular bag, kept it on the anterior surface of the iris, and then one of the haptic was taken out. We cut the IL into two pieces. As you can see, because holding it so that it won't flip it and hit the back of the cornea. Cut the IL into two, and then the pull and dial technique. Just held one of the haptic. The frequent viscoelastic injection is important to keep the IL away from the cornea endothelium, and this is how you can take out the IL. And then we went ahead with the 28 diopter sphere of the IL was implanted with the capsular bag. The wounds were sealed well. So after sealing the wound, we didn't found any leakage. So, and this was the post-op result. On the first post-op week, the refraction was plus 1.25 diopter sphere with 0.5 diopter cylinder at 140 degree. The BCVA was 20/30 with the glasses. So the reasons for this, again, a refractive surprise of 1.5 diopter could have been because of the overestimation of the central corneal power by the IL master, and which could have affected the derivation of the ALP in this particular case. So IL power, which was 28, should have been around 29.5 diopter. Now the biggest challenge was in this particular case when we took up the second eye for the cataract surgery, which had a 16 cuts RK surgery in 1994, and patient was wearing at that time 2.75 diopter of glasses with 0.75 diopter cylinder at 20 degree. The biggest challenge in this particular case when we took up the second eye was getting the right center corneal power and working on the incisions, because now here the scenario was different because the first eye had a 8 cut. Now this eye is having 16 cuts, so you don't have much space now for the main incision to be put. And then choosing the IL and IL power was the important point in this particular case. So what we did was we actually this is the pentagram measurement of central corneal power. So as Dr. Rajan has suggested, we went for the smaller zone of the central corneal power, and it detected around 34.13. IL master gave 33 this time, and then we took up the Barrett's formula. This was the ASARS formula, which gave us 29.404 diopter. Barrett gave the IL power was around 30 diopter. So looking at the previous history of the eye, what we did was, because since there was a 1.25 diopter under correction, so it comes to be around 1.75 diopter with the calculation. So we added this 1.5 to 1.75 diopter, what we got actually with the ASCRS and the Barrett formula. The maximum power which was detected was 30. So we plan to implant a 31.5 diopter sphere in this particular case. So surgical procedure was very important because now since there wasn't much space, so we decided to go to do a make a scleral tunnel for this particular case, bend all the posterior limbus. These are the two options. For the side ports, we could go in between the intersection. And this is the main incision. What I'm trying to make is going through some amount of the scleral part. But when you're entering from the sclera, this was just 1.5 millimeter away from the limbus. You still have to keep the incision between the two available incision, the widest available incision. And this is how we could do it. And the rest of the surgical procedure was standard phacoemulsification. This patient had a little hard nucleus. But the important point is you have to reduce the infusion pressure so that you do not make the problem in the arc incision. This patient also had a floppy iris. So there was a sudden meiosis of the pupil, and some of the nuclear pieces were in the process of removal, and then which we completed, and then injected phenocane to dilate the pupil, intracameral phenocane injection, and then completed the cortical aspiration. But as you can see, the pupil again went down, and now because we had a scleral tunnel incision, supposed to two posterior incisions, so you could have a iris prolapse as this patient was having. And this is, then we went ahead with the 31.5 diameter of the IOL implantation into the back. And the wound, actually, the main incision was quite well retained, but just one of the side port had a mild gaping here of the arc incision. But when we were sealing the incisions with the injection of the saline, so we could see, right, even this wound also sealed very well. So we didn't need to go ahead with the suturing. So the first post-op day in this particular patient, the result was the refraction was minus 0.5 diopter sphere and minus 0.5 diopter of cylinder at 85 degree, and patient was improving to 20/30 vision. So this actually the quite satisfying result, because to conclude the important points, which the first and important point is the challenge. The patients with prior RK difficulty in achieving the post-cataract surgery target refraction. So this is the most important point. And what I have found was ASCRS calculator, Barrett True K history, True K or partial history if you do not have the history, or True K no history also works very well. And Haggis L formula, again, the preferred choice for post-RK cases. And this third important point is always aim for a myopic refraction between -1 to 1.5 diopter to minimize the post-operative hyperopia. And what I normally do, whatever maximum power you get with any of these formula, add 1 to 1.5 diopter sphere plus into the final calculated power. So this is what was done in our the second eye of this particular patient, and we could succeed to get the final emmetropic vision in this particular patient, and the patient was quite happy after this, and as well as the surgeon. So thank you very much. I'll stop the presentation here now. Thank you.
Thank you, sir. Thank you for sharing such a wonderful video atlas and enlightening us on all the different aspects of post-refractive surgery, biometry, as well as on cataract. Over to the panel for the discussion.
Very good call.
So this actually, because Dr. Mohan Rajan, I will have your comments, because as I have shown in the second
I will
eye,
tell you one thing. After so many years of practice, still I have not got my results good post-RK.
Yeah.
some reason, I don't know, because so many variables are there in this, very difficult. But what I would differ from you in certain ways. One, of course, is the formula you use. You can go by the Barrett and if you have access to optical biometry, you can do that. And the IOL Master 700 gives the post RK. That's one aspect. Second aspect, the surgical aspect. Okay. And the first case I saw you put a corneal incision, though it was only 8 incisions there on the keratotomy. But I would prefer only a scleral incision, and I would put very less number of incisions into the eye. That is, I will not use bimanual at all. I'll use only coaxial. I always use coaxial only. I don't use bimanual unless it's a posterior polar or when I have a PCR or something. So I have 2 incisions only. One is the main incision, which is a scleral. The second incision is a side port, which is also very less, which is also will be scleral or posterior limbal. So you don't, and in between the RK cuts. The one thing I have noticed in RK patients is that my Centurion machine works wonderfully well. Reason why? Because I'm able to control the IOP to the physiological levels. I keep my IOP at only 20 or even 30 for these patients, so that there is absolutely no stress on the RK incisions at all. Because all of a sudden the RK incisions can leak, can open up, and it'll be a really messy affair. Okay, sometimes you might have to put horizontal sutures, vertical sutures, and all these problems can occur. So I think otherwise you have dealt it well. But first case, I'm not sure why you should have. See, how long you waited for that +3 before you do
The first,
post-operative.
yeah.
Yeah, then after some time it may settle down.
Yeah.
Normally I wait for about
6
a month
months.
or even, how many weeks you waited for that?
This patient was taken up for the IL exchange after 6 months of the
6
cataract.
months.
Yeah.
Yeah,
And
that's fine.
first query, Dr. Mohan Rajan, which you raised was in the first eye. This patient had 8 incisions only, and there was enough space of 3 to 3.5 millimeter space between the 2 incisions. So I made a 2.4 millimeter of incision, and which was quite sufficient area available for the incision. So I didn't have to go for the scleral tunnel kind of incision, which I made in the second eye. So in the first eye, I went through the corneal incision only, and it was fairly okay and stable.
I understand. Since you went to that.
If you do not have the space, then definitely, if you do not have the space, the enough space between the 2 incisions, then definitely you have to go the posterior limbal or the scleral incision. Yeah, definitely.
Yeah, and also because these patients are all high myopes, and you saw that it is not the iris is floppy.
Yeah.
It's a fluid misdirection. What happens in high myopia? What happens is the fluid goes underneath the iris.
Yeah.
Pushes the iris forward. You think it's something like IFIS. It's not IFIS actually. There is actually a fluid misdirection. So what you need to do is go with the second instrument and then tap the iris and go underneath between the capsule and the iris, and just tap the iris forward, and automatically the fluid will go in front and make sure that because otherwise it's a pupil which will go up and down every time. You go inside the eye. So it's all patients who got high myopia because their zonules are also a little weak, so they go down and push the iris forward. So that's the reason why you have this problem. And also, I would prefer a soft shell technique for all these patients. So you put viscoat, and then underneath you put Halon, and then that works wonderfully well. That keeps the iris back, and this works wonderfully well. There's very, very little turbulence of the iris. And no, I would not prefer a bimanual, especially when you have 16 or 32K cuts on the cornea, because I don't want too many incisions into the eye, because you have too many incisions, you have problems. Okay, any incision can open up anytime during the surgery. So I think Gaurav is also there. I think he can also give his opinion on this.
Hi, Dr. Monrajan sir, and very good evening, everyone. I'm really sorry my flight, there was a lot of bad weather in between Dehradun and Jaipur, so it delayed by almost 30-40 minutes. But I did manage to catch most of Dr. Rajendra Prasad's talk. And as far as RK goes,
Sorry.
I think I'm usually I kind of agree with almost everything that you've been discussing, all of you have been discussing. But one place where I would, two areas where I would probably differ a little bit, or maybe not even differ, it's just that my way of approaching it. I would actually, Mohan sir, I would actually do a bimanual because, the bimanual incisions are 23 gauge. So they can be easily put between two incisions, and I like to minimize my manipulations or entries into the main port because the main port is usually the bigger one, it's like maybe 2.2 or whatever you're using. So what happens is every time you go in and out of the main port, you're basically increasing the chances of one of the incisions opening up. So what I typically try to do, in fact, I prefer to do femto-assisted surgery because I have already got a rexis in place. I've already cracked the nucleus into 6 pieces, and I've already got a hydrodissection done. So the manipulations inside are minimized inside the chamber. In fact, because these are very high myopic eyes, so usually the chamber will be very deep. So when you enter with the phaco probe, usually you are dipping your phaco probe down. What you say in the IOP at about 20 or something, you won't have a very deep chamber. So you can approach the nucleus. So I personally feel that if femto is available, it is a great way to includes doing the rexes, chopping, separating the neutral section. Almost all these things are minimized, and you can
Not able to hear you.
go through the main more
I
chances
think
for
he's
Lost him.
traveling, so that
uh,
could be the reason.
Right.
Yeah, he's muted again. Please
okay.
unmute
So
yourself,
I,
sir.
I will I will switch my video because that way I think my connection will be better. Am I audible now?
Yeah,
Yeah,
yeah.
but
No.
Yeah,
Okay.
that's better.
So I think
That's
I've
better.
conveyed my point. I'll be happy to share a video or two if you would like to see how I approach it. But I also agree that Mohan sir said that corneal incisions can be problematic. I like to do a limbal incision. I don't like to make conjunctival flaps, but I go straight at the posterior limbus and try to make a 2.2 and minimize the manipulations as I just discussed. But in spite of that, occasionally you'll have an incision opening up, and you should be prepared to suture it if you have to.
That's right.
I just want to add one or 2 points more, and whatever has been explained is a wonderful and nice tips given to our viewers. These RK patients, they keep on changing their corneal power. If you measure in the morning and measure in the evening, you
Hello.
basically find that there's a difference of 0.5 to 0.75 diopters. This is what I've seen in a lot of RK patients. So it is always better to call them in the evening once their hydration goes back, and that would be a proper way of calculating the corneal reading. And the point which was given by Dr. Prasad, that always keep or add +1 diopter or 1.5 diopter, that basically takes away all the hassles when the patient opens up eye in the morning and he has got blurred vision if the IOL power is not being um, um, uh, increased by 1 or 1.5 diopter. So this is how it practically manages that in the morning, patient has got practically a good vision, but as the day progresses, he is going to have a better vision, particularly in RK patients, because the hydration goes back. So that gives an additional kind of thing that patient really does not go into a hyperopic correction in the morning, which is a usual phenomena with RK patients. And by the evening, I mean, say if you've added 1 diopter, morning vision is practically reasonable. By evening, once he goes to the office and every place is to move around, his vision is practically very good. And I always take a scleral incision, taking out a conjunctiva, doing a little bit cautery. Whenever I reach to the limbus, I just enter inside and do my other maneuver inside the anterior chamber to crack the nucleus and do the frequemulsification with the low parameters. Yes.
Sorry, sir. Yeah.
I think we'll move on to the next speaker.
Yeah.
Dr. Bali, sir.
Please.
So our next speaker is none other than Dr. Gaurav Luthra. He's a cataract and refractive surgeon and is the medical director of Drishti Eye Institute, Dehradun. He is no unfamiliar face, and we've all seen him operate in various live surgery sessions in the major national platforms and internationally. He has special interest in refractive surgery and challenging pediatric cataract surgeries and keratoconus. He's the chairman of academics and past president of IIRSI, and is also the founder member of World College of Refractive Surgery. He's had 5 auditions and 4 named national awards and has demonstrated over 200 live surgeries. We welcome you, sir, this evening to talk about your experiences with the surgical imperatives in post LASIK and PRK patients.
Thanks a lot, Dr. Anu, and thanks a lot, Dr. Jatinder, for inviting me. And I'm afraid, I've kind of spoiled the whole session as I didn't want to kind of do that. But I'm going to share my screen now, and I'll be happy to share some of my experiences. I missed the previous 2 lectures, so I will not know exactly what was discussed in the first, because biometry remains the most important aspect, and I'm sure Dr. Nechalani would have done, an amazing, task with that. So, uh, going on, I hope you can see my screen. I've switched off my video so that my
Yeah.
You can see.
great, great,
Yeah.
Dr. And I congratulate you on organizing these new series, and I'm hoping that they will be as informative as today's seems to be. So I will be speaking on cataract surgery in post LASIK and PRK eyes, and I'll try to cover up a few things. I do have 1 or 2 interesting cases to share as well. So I think we've all probably discussed so far that post-refractive surgery challenges remain with the PRK and RK and LASIK eyes, and also with hyperopic PRK and LASIK eyes. So these will obviously have different ramifications, and refractive surprises are entirely possible. I did over here Dr. Rajendra Prasad talk about his refractive surprise in the RKI. Now these are usually because of fallacious determination of the true corneal refractive power. I'm not going to go into any details. I'll just have 1 or 2 slides talking about why we will get difficulties with ALPAR calculation. So I think what remains most important is the altered ratio of the anterior and the posterior corneal surface, and more so in RKIs, where the changes are going to be more significant, unlike LASIK and PRK, where the posterior corneal curvatures don't change really, and therefore the incorrect estimation of the ELP and the corneal sphericity. So these are the reasons why we might have refractive surprises. I will not go into the details, but and this is how post-refractive surgery LASIK will differ from RK, how it changes only the anterior curvature, whereas in RK you will have central flattening of both the anterior and the posterior curvatures. So going on, I think Dr. Rajendra would have covered all this, so I will skip this, and I will come on to some of the newer measurement methods which I've been using for post-refractive surgery eyes, including RK, LASIK, and PRK eyes. So the ILMaster 700 does have a very good method of the posterior and anterior corneal curvatures with the TK. I will again not go into the details, but I did over here that all the formulas were spoken about, which are available on the ILMaster 700. And it has definitely given a good, fillip to our calculations. The second thing which I really trust is, especially with very, very flat corneas, is the Pentacam Holiday EKR report, which essentially gives us, the EKR zones from the 4.3, 4 to 4.5, whichever you might want to choose. So I usually end up using this as a very, very good tool for checking out what I'm going to use for my, especially some of the very flat corneas, which are not amenable to measurement with the optical biometers like the ILMaster or the LensStar, which have a limit at about 30 diopters. So I do sometimes operate patients who are much below 30, like the 23 and the 24s, and the Pentacam can pick up cases which are much, much flatter. So this is how you would look at that, and that's how you will pick it up. And then, of course, I'm sure we've discussed the SRS calculator and the Barrett's online calculator, which has options for, frankly, for keratoconus and, for the other eyes, which are the TK and the other formulas. So going on, what I've been really using, I don't know, Dr. Bali, was ray tracing discussed during the session today? I'm sorry, I can't hear you.
No, we've not
Okay, so
discussed
I'll
ray
cover up
tracing.
2, 3 slides because I've started using ray tracings for some time now, and it seems to add a lot to our, accuracy of getting post-refractive surgery eyes. So the ALPAR calculation using the ray tracing can be used with several devices, and it does not require pre-LASIK K readings, and also it does very good job with almost all kinds of refractive surgeries. So you can see there that it can be actually, the data can be derived from several devices. So It's useful for eyes which have undergone previous refractive surgery, and it does not rely on the fixed ratio between the anterior and the posterior corneal curvatures, but instead is based on the curvature measurements of both surfaces. So it does not need any historical information, and it does not estimate the IL position from the corneal par, which was one of the lacunas, as I talked about, that the ELP goes wrong because we are trying to determine the ELP from the corneal par in most of our formulas. And it can be calculated over various diameters depending on the pupil size and the optical zone. And it does not perform para-axial calculations, but instead it takes into consideration the higher order aberrations, which can be relevant, especially in eyes with post-RK. So it directly performs calculations for the cylinder and the spherical, both in case of corneal astigmatism. So going on, I think we've all understood that ray tracing has been talked about for many years, but it was not practically possible to do it because most devices were lacking it. But with the newer devices which are now able to measure and provide data to the Oculix formula, which is used for the ray tracing calculations, you can use it for many of these eyes, including silicon filled eyes with piggyback IL calculations and phakic lens calculations as well. So these are all the devices actually. So, and many of us will have one or the other of these devices which can actually use data onto the Oculix. So from most of these devices, you would have to actually feed data from the device into the Oculix. But one of the devices which has incorporated the Oculix into it is the Anterion, and I think even the MS39, if I'm not wrong. And we recently started using the Anterion for our ray tracing calculations, and this is one of the patients which was post-RK. So you can see that the pachymetry maps are almost pristine. There's not much which has changed. But if you look at the central flattening caused by the RK incisions, you would see the anterior and the total corneal parts which are totally changed because of the central flattening. And this is the fellow eye. So both eyes are showing central flattening from RK. And if you look at the Barrett's true K formula for both the right and left, you'll see that is estimated 17.5 diopters here. And when you look at the left eye, for doing the calculations, you'll see the calculation coming up, and it is basically going to give a 19 diopters here. This patient actually have planned surgery now, and I will be sharing with you maybe I'll send in the information of what finally came out. But these are very exciting systems of how we can look at these calculations, and ray tracing is coming up as a very great option. We've been experimenting with it for the last few days and found it useful. So now coming quickly to what are the challenges in post LASIK PRK eyes. Frankly, good history is very important. Every patient should be presumed to be a post refractive surgery today, because there are so many post refractive surgery patients now. We should probably be asking our optometrists and ourselves maybe just a casual quick question that, have you undergone any kind of laser corrective procedure? And many people would actually either forget about it, or they don't like to discuss it, especially some ladies who are in the presence of their husbands wanting to hide the fact that they had undergone a refractive surgery. I had one even yesterday who just would not, had big number of RK incisions, would just not, and I immediately understood that she's trying to hide, and I had to protect her privacy as well in front of her husband by kind of taking it into another direction. So we have to be also very careful. Some of the patients, if accompanied by the relatives, may not want to disclose, and you have to respect that. So look out for very flat and very steep case. Look out for thin corneas, which are extraordinarily very thin in the central area especially. And look out for an unusual pachymetry profiles, which means that, if the cornea is very thin and you are seeing that the progression of the into the periphery is very fast. So, on the pentacam, you can actually see it well, but even on other devices, on OCT, you can pick this up for the cornea as well very easily. And as I said, suspect every eye unless proven otherwise. So also please look at, once you have found that it is a refractive surgery, be sure whether it's a hyperopic or a myopic. Just last month, one of my staff members made the mistake for a patient who was post-hyperopic LASIK, and on the SRS calculator, they actually entered it as myopic LASIK, post-myopic LASIK. So we were getting a totally wrong IL calculation. I was lucky to kind of pick it up. Otherwise, they assumed that it is always going to be myopic because hyperopes are very rare. So especially if you have a post-hyperopic LASIK, please ensure that you're using the post-hyperopic LASIK formula, and not the other one. So look at the the optical zone of the ablation, look at the centration of the ablation, look at the irregularity, if there's any irregular astigmatism, decentration, because then your choice of IOLs will be very, very limited. And of course, if astigmatism is there, then whether it is a symmetric bow tie or not. So all these things would help you decide whether you would still want to proceed with a toric IL post LASIK or post PRK, because it can be done. It's not difficult to use that. And then also look for the changes in asphericity, because the Q value will tell you what kind of lens would you like to put for this patient. So going on, actually, if you actually come to the surgery post LASIK or PRK, frankly, there is nothing that you will do differently because once you have got the IL correction right, the surgery essentially remains the same. And this is what we have to tell every patient who have fears that getting a LASIK or something done will not be able to get a cataract surgery later on. And I've been 20 years and I've been explaining to patients that please don't worry about your cataract surgery, worry about only what you're choosing right now, and just a good clean surgery with a well-centered IL placement. So I'll quickly share, Dr. Bali, if it's okay, I'll take 2 minutes to share this interesting patient where
Please,
was
sir, please.
very highly motivated to get a multifocal implant post LASIK, and she came up to us and she kept going around, I think, several places for almost 6 months trying to find out if that's possible. I initially demotivated her. I said, not a great idea at the most, because she didn't have much astigmatism. I offered her that I would, be happy to use EDOF kind of a lens, but not a multifocal lens. But she wanted excellent near vision. So finally, we worked her up thoroughly. And we found that, of course, she had good pachymetry maps with central ablation, 450 microns in both eyes. And the optical zones were fairly well centered. And while you can see that the green areas are showing the central ablation, but if you look at the numbers there, they are not very, very far apart, which means that it's not a very irregular ablation. It's fairly a decent ablation over there in both the eyes. And the optical zone are well maintained. These were the epithelium thickness maps. You can again see the epithelial hyperplasia in the central areas for both the eyes, and which is also uniform. So therefore, no irregular kind of astigmatism there. And bad maps are, of course, of not much use in post LASIK eyes, so we just don't need that. But the EKR maps are very, very useful. So we did use the EKR maps, and you must look at the distribution and this curve over here, which tells you about if it's a very, very flat curve and not being able to show you the correct case, then you're in a situation. But these cases look good for me to proceed. And once we were confident of her maps and everything fitting in, then went to the ALPAR calculations. The eye trace showed, some very few corneal aberrations, as you can see on the left side, and this fellow eye as well. So the corneal aberrations were not bad at all. And we also looked at the angle alpha and the angle kappa. So here, actually, it's the angle alpha, which is more important in case you want to proceed with this. Went to the Lenstar, did all the calculations with the Barrett's True-K, and then we went to the ASCRS calculator. And frankly, we were lucky because, it was, except for the Pentacam Potwin Hill calculation, which was showing only a 16.56, almost all the others methods were showing just about 18 to 18.2 diopters. So it was pretty straightforward, because when you have a lot of disparity between these numbers, then it becomes problematic. But when you are having similar numbers on all your calculations, for example, the other eye also, you can see that most of them are showing in the same range of about 18.87 to 19.34. So we use a 19 diopters here and the 18 diopters in the first eye. So frankly, we got an excellent result. This patient, if you'll notice on the top right, had a post-op refraction of about this much, 0.12 with 0.75 cylinder here. And in the other eye, had a refraction of almost plano with 0.37 cylinder over there. Patient did extremely well, and was very, very satisfied, and had good reading ability. So this is one of the cases I almost always never use, post-op this thing in post-refractive surgery, as I would usually demotivate these patients for any kind of multifocal implants. But occasionally, if you think that everything seems perfectly right, you can still go ahead. So I'll not show you the RK ones. I think I'm done because I've already taken my, femto-assisted surgery, how it can be very useful. And I'll stop sharing the screen at this time. And if you ask me, then I can always share it again.
That was a brilliant presentation, Gaurav. Fantastic.
Thank you, Mohan sir. Thank you so much. I'll be happy to answer any questions or anything that.
We use the Kane formula, Gaurav. Kane.
The Kane formula is amazing. For my keratoconus eyes, I've been using the Kane formula as well, and it's really, really good for those eyes, and especially also some of these other, post using it for. But I enjoyed the Barrett's True-K, and also use the AS calculator a lot. So I've been happy with my post RKIs using these methods as well.
So one message is very clear from what Gaurav has just now mentioned, is that now with the advent of all these formulas, and newer optical biometers like Oil Master 700, and also the newer generation formulas like the Barrett and the 2K formula, as well as the Hill RBF, the Kane formula, and other formulas which are based on the artificial intelligence. We are able to get it bang on the target, and we are able to now tell confidently, because about a few years back, I never used to put multifocal lenses for these patients post LASIK because I'm not sure where we are going. Because if you are not going to be there, then you are going to be in trouble. So nowadays we can confidently tell, because we can, as Gaurav rightly beautifully mentioned, we can compare all the formulas, the different formulas, find out whether they are matching very closely to each other, and then probably arrive at a solution. And most of the patients are do very well. One important advantage we have with the post LASIK patients is that these patients are all very motivated, and they want very good near vision because they have had good near vision and for quite some time, and they are very motivated, and they don't mind some glare, halos, and all. They will not. It will not bother them much because a very motivated patient and very happy with whatever. Even if you give them 6/9 N8, they'll be very happy, and that's the reason why I think multifocal lenses, if they're not corneal or higher order operations. The angle alpha, I'm not sure, Gaurav. I don't give too much importance to it. Normally, they say that more than zero point 0.5 and all, you should not put focal lens. But nowadays we have the EDOF lenses, which has got a central zone. For example, Symphony has got a central zone which is more, or even a VVT which has got a central zone is more. We can go ahead and do that in these patients as well. So that is my opinion. Gaurav, you have anything to say?
So I think we've lost Gaurav. Actually, he's driving down, or is he there? No, I think we've lost him. We just lost him.
No, I
So,
think he switched off this video only.
yeah, he had, sir. He'll join back. But basically, he's driving down. He's back. No, that's that there he is. Please unmute yourself, Dr. Luthra.
Unmute.
Please unmute yourself. Dr.
So
Gaurav,
I had lost network for 2 minutes, and I'm back now with the network. So I hope I'm audible. I don't know what I missed in the discussion last 2 minutes.
No, you got very glowing praise from Dr. Mohan Rajan, and you missed that.
And Dr. Mohan has actually joined. He was not well for the last few days, and I'm seeing him a little, pull down as well. But so all credit to you for always there, sir. I mean, I'm amazed by your energy and enthusiasm without any doubt.
The moment you said multifocally, he gets up. The premium IOLs perk him up.
No, Gaurav, I was telling that nowadays because of the advent of so many gadgets and so many formulas, new generation formulas, we are able to hit the target. And now confidently, a few years back, I was not doing multifocals. I used to be very apprehensive when somebody asked for multifocal lenses. But nowadays, I'm confidently able to put synergy or VVT, whatever the patient wants. But because that mostly I'll be hitting the bullseye in many of the cases. And also, I was telling that these patients, you don't have to counsel them much because they are very motivated patients. Okay, these LASIK patients, they're all motivated already, and they are motivated to this level. And you need to take them from that level to the higher level. That's all. And if they have vision 6/9 N8 vision, also they're very good. That's what I was telling before you came.
Can I speak, Dr. Mohan Rajan, for 1 minute?
Yeah. Please, sir.
I think we have a very lavish discussion on the post-refractive cataract surgery, and all the stalwart had given their opinion. What I have seen, initially I was working in a government setup, and I operated more than 1.5 lakh of the patient, and I have implanted more than 500, 600 of premium IOLs like multifocals and Symphony by Dr. Mohan Rajan was talking. But now I am in practice. So here the situation is different. here you have to be little more committed to the patient, like what you are talking and what you are going to do. A patient always keep these words in their mind. So what I one word I will like say to all these stalwart, they are definitely having a better experience than me, that we should avoid the unrealistic commitment to the patient. That is the biggest thing for your success in the practice. That will reduce your mental pressure as well. And definitely a extraordinary workup for all premium cases, and particularly when you are handling a patient of the post-refractive surgery, then your work increase a lot. So we have to do a very meticulous workup for these patients to avoid or to face any any unexpected refractive surprises. That is the biggest thing. And I would like to congratulate Dr. Bali that you have organized and you are just start a very nice topic to give a word of wisdom to all the practitioners who are joining with you, that they definitely can develop their confidence, their mind with the words of these stalwarts who are handling such a large scale number of the premium lens implantations. I mean, everybody has scared. Suppose I have to charge 80,000 people, 80,000 rupees for the patient. Naturally, my responsibility increase manifold. So these words are always
Definitely.
magical for everyone. So I really thank you, Dr. Bali, for initiating such a good series of it. And please, I request you, please continue it. And please ask all these stalwart, they should be connected with us in all kind of small problems that we have to face in future also.
Sir,
Thank you
actually,
so much.
it is these stalwarts who've actually made this program feasible.
Oh
It's
yes,
that
I
intangible knowledge that they bring into the program, and the
this knowledge boss comes with the lot of work done by you. You have to face a
exactly.
lot of work, you have to done a lot of mistakes, then you improve yourself, and then you come over with a concrete formula how you face it ultimately.
And the good thing is that they are master communicators. So
Absolutely.
it's really been great having all of you here. And actually, I wanted to pit Dr. Gaurav against Dr. Nichlani,
Yeah,
and
Dr. Nikilani, Gaurav, and
yeah.
Dr. Mohammed, all, and Rajan Prasad. I mean, they people are the masters who are handling and having the courage to give the word of commitment to the patient. If they are charging high, they have to give a very high result.
Exactly. And so the main driving force behind this is that this is something that is being done by you know very high quality work being done, and it is unfortunately not translating into our, like, it's not going from work and journal into the books. So
Yes,
there's a lot of
absolutely.
what do you call it, mental cobwebs that people have on this issue.
मैं आपको बाली जी बताऊं, मैं जब से आपका ये वेबिनार मैंने मैसेज देखा, I was trying very hard to find out that how many percent of our cataract surgery are coming in this group of refractive surgery of cataract surgery cases. So मैं देख रहा था कि it is 10%, 20%, 30%. Suppose you are operating 100 patients of cataract in a month. How many percent of case or having the history of refractive surgery is already studied by someone? So I couldn't get it. If someone have the idea, I mean, I will love to listen it. That suppose you are having 100 cases and you have only 5% cases of it, I think you will not matter of it. But suppose you are getting 30% cases of having refractive surgery, either RK or LASIK, then it definitely matters. So
But so
if
these
somebody
are
have,
very challenging cases,
yes,
because you see, this is like you have a level 1 trekking trail, and you have a level 7 cliff. So these are like level 7 cliffs, and most
I
of these
totally agree.
people, yeah, and most
I
of these
totally
people
agree, Bali.
tend to be, the wives of somebody or somebody known to you, and that multiplies the challenge that many fold.
One thing I would like to convey, that this group of patients who has undergone refractive surgery means they are the people who are always looking for a best vision. Never afraid to pay high, because they have already gone for this one of the procedure. So these kind of patients are having high expectation, and to come up to their need, I think we have to work a lot, and we have to share and understand the experience of the seniors who have already a big experience around these cases.
So, sir, I will take this occasion to thank Dr. Nichlani, Dr. Mohan Rajan, Dr. Gaurav Luthra, Dr. RP on behalf of Dr. Anand, Dr. Anu, Dr.
Yeah.
Ramesh, and all the people who are watching us. There are 2 or 3 questions which have largely been answered already in one form or the other. And of course, people want to talk about keratoconus, which we'd specifically kept out of the present discussion, because that is, that's again a slippery slope, and trying to put it here would have confused the issue just too much.
Sure.
So I, with the permission of Dr. Rajan sir, Dr. RP, Dr. Anand.
I want one message, clear message from
Yes, Dr. Rajan.
all the expert faculty here. So is the message I want to message, because there are, as you rightly said, a lot of delegates, a lot of ophthalmologists are working in the rural area. They don't have access to optical biometry.
Yeah,
So
absolutely.
what do you suggest to them for post-refractive surgery?
Yeah, I think that's a very nice question. So let's have the panel, interact on that. So we'll start with Dr. Nichlani, Dr. Gaurav, Dr. RP, and
Yes.
Dr. Rajan, and Dr. Anand.
Yes.
In that
Yeah,
order. Let's start, sir.
absolutely.
So our question is twofold. You're doing a premium practice and you have access to everything. That's one. And B, you
That
are
has
doing a
been
normal
answered,
practice.
Vali, Jatinder,
Yeah.
that has been answered already. You are
Okay,
doing
fine.
the
So a
premium
monofocal practice is what you're doing, and you have access to. So what should you be doing if you have a monofocal practice? With restraints, without constraints. So do we start with Dr. Nichlani first?
Yes. See, basically, it all depends upon your past experience of dealing with all those patients, and gradually you keep learning with the different tools you have. So once again, my message would be very clear to the beginners, particularly who want to start this kind of practice with the post-refractive cataract surgery, how to go ahead with implanting monofocal and later on going with the premium IR, that you need to have your past experience calculating out, trying to see that RK patient and the post-refractive LASIK patients, how do they behave with the calculation of true corneal power and effective lens position. Make a chart of it, try to see that where exactly you went wrong and evaluate it. So once you evaluate all those things with the available tools with you, even if not the optical biometer, the the true K axial length, putting into the different formula and the newer generation family, comparing it with the different family, try to get the resemblance in those family will definitely take you to area or to a IOL power calculation, which gives you a effective power which is near to emetropia.
Great. So basically, what you need to do is whatever you're doing, just tabulate it and keep on studying it and keep on analyzing it. So we could come to Dr. RP.
See, actually, frankly speaking, I started my premium IOL surgery and practice with basic tool of immersion biometry only. And you see, because it's as Dr. Nishlani has said, like you gained with the experience, like what exactly you need to do with your biometry when you are planning for the premium IOL. It's very important, like you don't leave it with the technician. You do yourself and do take a multiple readings. See, actually taking just one reading won't be very sufficient, because you're not doing the IL master, because IL master, just the one reading or one click gives you everything, but not the biometer, ultrasound. With the ultrasound, you have to be very sure, like you are putting the probe at the center, you are putting the probe straight on the center of the cornea, your cornea is hydrated, it's not dry, and then you have to look at the scan, what you have got. Look at the scan. It should be absolutely clear scan, and the last scan which is coming from the retina, it has to be flat. The top has to be flat. If there is a wavy thing on the last scan, then you may have a wrong reading. So these are important because your scan, if you're doing a good scan yourself and you know that what right you have done, what wrong you have done, and we are taking the right decision, then you can bang on the refractive error. There is no problem because we started with that only, and I did a lot of premium IOLs just with the ultrasound only. But now I have IOL Master because now definitely the results have definitely improved with the IOL Master. And when you're talking about the premium IOL, this is one important point. And second important point which I want to highlight is especially when you're dealing with the post-refractive cases, and especially RK surgery, even the LASIK surgery also. I have a lot of reservation in going in for the multifocal or the trifocal or the EDOF IOL, and especially EDOF IOLs when you have a lot of abrasion created on the surface of the cornea with the LASIK, the high refractive error, astigmatic error, and most of these EDOF IOLs are the modulation of the abrasion, the spherical abrasion modulation, which is the basic way how the EDOF IOLs work. And if you already have a lot of abrasion on the corneal surface, then these EDOF IOLs, instead of giving good result, they will give you a worse result. Even the patient will suffer having a good distant vision. Forget about the reading. So I'll have a lot of reservation in doing the multifocals, especially the EDOF IOL in the post refractive surgery. Trifocals, yes, definitely, because trifocals, if you are planning very well and if you are looking, as Dr. Gaurav said, like you have to do a good scanning of the cornea and you have to be sure there are not irregularity on the cornea, there are no irregular astigmatism, your corneal surface is clear and not too much of abrasion. You have to measure with the eye trace the abrasion on the corneal surface. If you are sure that everything is okay, then you can go ahead with the multifocal or trifocal lens.
So, sir, the take-home message from you is you have to, A, it's challenging. B, you have to be hands-on. Don't leave it to the other person. Do it yourself, especially if you're not, if you don't have access to the other things. When you do it yourself, because your intangible knowledge and understanding will bring additional signals into this IOL power calculation. And be a little wary of the premium IOLs, at least at the beginning, till the time you do not have access to better equipment. Right, sir?
Right.
Perfect.
Oh.
Perfect, Bali.
Okay, so now let's go to Dr. Luthra.
Thanks, Dr. Bali. In fact, I think all the points raised by both Dr. Nishlani and Dr. Rajendra Prasad are actually all the gems in the pearls. But all I would like to just add, maybe in a small way, is that frankly, problem with the post-refractive surgery eyes is not, with the axial length, because immersion can give us very good axial length measurements. So optical biometry, the challenge is basically with the corneal measurements, because first thing is to pick up whether the corneal measurements, first of all, whether the ablation or whatever we are doing, the optical zone is good or not. So a topography would actually be very, very important to pick up what kind of refractive surgery, whether it is well centered. So if anybody is delving into operating on somebody who's post-refractive surgery, now he has to decide whether his patient has high expectations or not. If his patient has high expectations and expectation for spectacle independence and great outcome, refractive outcome, he will have to take up the challenge of getting good corneal measurements. Otherwise, he's going to go for a surprise. So axial length will come from immersion very nicely. That will not be a challenge. But if he goes for an autokeratometer or a manual keratometer, he will not be able to get the correct case. And frankly, all these new formulas like the Barrett's 2K will not work. Especially, they always work only with optical biometry. So there's no point using manual measurements onto a Barrett's 2K or a similar formula. So I think, but there are other formulas which are available for people who are not able to do optical. I would suggest that either a person would have to, even if you don't have these devices on your own, there are now devices available in your city. Most people will have access. They can refer the patient for maybe a pentagram or for an optical biometry to a colleague who does it. I get a lot of referrals because I usually have all these devices available. So I have so many of my colleagues from around referring for these measurements, and we happily do it and send them back because the patients can. So I would strongly suggest that if you have a demanding patient who has high expectations, make sure that you're doing the right thing and with all the measurements, corneal measurements and everything, so that you don't have a surprise or an unhappy patient. And if you feel that you cannot do it yourself, I would happily refer it out. There are so many things which I refer out myself if I'm not able to do them. I would not hesitate, because that would be in the patient's interest and later on in your interest that you don't have an unhappy patient. Yeah, absolutely, Luthra. This is a very correct word you have said, and that we have to look the patient's expectation. If we very highly expected, demanding patient, we should be very clear about the giving the words, and the unrealistic commitments should be avoided. It's very correct. Thank
So
you so much for
basically,
your words.
so let's sum up Dr. Gaurav's advice, basically, that
Yeah, perfect.
have
Very, very
collaborative
nice.
networks. Yeah,
Yes,
well
very
said.
nice.
Have
Very
collaborative
nice.
networks. Don't
Yes.
let your patient down. Have collaborative networks. People are there to help
Can
you out.
happen
They
in the,
will help
just
you.
Yeah.
that can happen in
Over
the
to
city.
Dr. Rajan, sir.
No, that can happen in the city, what Gaurav is telling. I'm talking about a person who's in the remote area and who's having a post, because he's going to have also some post-refractive surgery patients. So I think people, if they have only a manual keratometry and emotion biometry, I think a manual keratometry, they can probably get approximately the central case somewhere, and immersion biometry. They can go ahead and post-refractive surgery, they can use some new formulas, data generation formulas. And only thing is, they should not go for premium IOLs. So probably a unifocal, don't go for premium. That is the message I want to give. Or if they have access to a good topographer, I think a basic topographer, I tell all, whichever conference I go, I tell all the patients, put your money not on your Benz car or Audi car or this thing, but put your money on an optical
That is great.
Yeah.
That is great.
Yes, put your optical biometry or the OCT.
Yes.
Optical
Yes,
biometry,
yes.
OCT, I think these are the things which are very, very
Yeah.
important for you.
True,
Without
sir.
a OCT,
Need
you can't have a
Very true,
practice
sir.
like
Very true, sir.
you can't even think of a practice. So
Yes.
the basic
Yes.
OCT, optical biometry, I think I'm sure not now, maybe another few years from now, 5 years from now, I'm sure everybody will be having an optical biometry. They will have a OCT, they will have a topographer, whether it's an ordinary topographer or a pentacam or whatever it is. I think this is going to happen, because about 10 years back, we never thought it is going to happen like this. But another 5 years from now, I think people are all getting aware of this. And they know the expectations of the patients. They know that they have to get the optimum results for each patient. And I think that's the way, and awareness among all the people, of the patients as well as the ophthalmologists also. The training is also much better than before. And I think they will take it to a different level. This should happen. And that is what I think. Technology should penetrate every nook and corner of India. So I think that should be the message I want to give everybody. Yeah.
I think let's close with the chairs with the chief guest's message that technology is going to become more readily available, and we hope he's the president of India in the next 5-6 years, so that we get the technology cheaper.
Yeah. Very good. Very good.
And I think I take the occasion to thank my moderators, Prasanna and Anu, for doing a beautiful and a wonderful job. Thank you, everyone. And with this, we beg leave.
Thank you
Thank you
so
so much.
Thank you. Thank you, everyone. Thank you so much, Dr. Bali. Thank you. Thank you.
Good night,
Thank
sir.
you. Good night.
Can we play the video?
Yatinder, thanks a lot.
Just a minute, sir. We have to play the video. Where is Nima?
Intro videos, is it?
Concluding video? Oh.
Yeah, let's
You're
conclude with the
prepared.
video. Where's Nima?
Oh, yeah. Nice.
Just playing, sir.
Yeah. If you told us the video, we would have ended earlier.
Technology,
the presidential video now.
Yeah, absolutely.
Right.
So we're waiting.
We've caught them by surprise. We still remember there used to be this one day we were after. Yeah, okay, so we have it here.
Sorry.
So we apologize for having, made you.
कोई बात नहीं. It's a
Yeah.
problem with the new technology. Always be a bit right. No problem. Okay. So Dr. Bali and everyone, I think we should make a good night to everyone. It's a great effort, and really thank you very much.
Nima,
A lot
are
of
you
people get
there?
message.
Are you able to set it up?
What happened?
Not there.
I think some technical issue.
Next
Yeah.
time, see it.
Be prepared.
Saying it, so go ahead. They've not had dinner and they've been working since morning.
But Bali, everybody enjoyed your this webinar. I mean, it's a really great success.
See,
So
compliment you.
when we have this galaxy of stars, people
Yeah,
enjoy it.
definitely.
It becomes-
That is your effort. That is your effort.
Good.
That was very catchy music. Next time
Very
we'll
nice.
play it, upfront. Thank you so much and good night, everyone.
Good night.
Good
Good
night.
night.
Good night.
Night.
Good night, sir.
Jatin
Thanks,
sir,
Dr. Bali, and
really
thank
my
you,
Yes, sir.
compliments,
Everyone.
my compliments to you for your sustained effort in promoting,
Sir, all your guidance, sir. All your guidance. And
knowledge and
Great
your
blessing. Great blessing, Dr.
1 minute
Maharaja.
ophthalmology, which I inaugurated, has become hugely popular. Fantastic.
Thank you.
Thank
Great,
you so
sir.
much.
Great,
Hats
sir.
off to
Great,
you.
sir. Great,
thank you
sir.
so much. Sir. Good night, sir.
Good night. Good
everyone.
night, everyone.
Good night. Good night,
Thank you.
everyone.
Good night.
Good night. Good night.